Thank you, Premier. Certainly I'm just as pleased with the number, with the one in front of it for today. The trend has been down, but it is one day. I do hope that we can see that continued trend, but I would sound a note of caution. We're going into a challenging phase in the next couple of weeks. I guess every phase has been challenging, but the challenge of the next couple of weeks is that even as community transmission goes down, those complex outbreak settings that are really hard to get on top of transmission in aged care, in the disability sector, even in our health services, they might end up with a baseline level of transmission that is harder to shift. I think it's great that community cases will come down, our mystery cases will come down. That means that the opportunities for introducing infection into an aged care setting, a supported residential service, even in our healthcare, our acute healthcare settings, the caseload will be less, and so the potential for outbreaks will be less. But the ongoing challenge of managing within those settings will remain. And so even though we're seeing numbers below 200 today, there might be a flattening off in the next couple of weeks if we don't really focus all our attention on those complex settings. And obviously the establishment of the combined disability response akin to the aged care response is a really positive development. We need an integrated response in the same way as we've set up with the healthcare worker infection task force. There are lots of systems issues that need to go through in all of those settings, right from the personal protective equipment, but also about the resident and patient flows, the flow of staff, the training and awareness, and the OC health and safety issues around infrastructure and ventilation and a number of other things. So that all needs to be looked at very carefully, and a systems approach needs to be taken to get across those complex settings, because they are not easy to manage. But it's terrific to see our new cases fall. And as I say, as community numbers come down, then the opportunity for outbreaks and clusters within those settings reduces. And of course, we're protecting our rural and regional brothers and sisters as we're driving cases down in Metro Melbourne. That's a really important aspect about why they've turned the corner. Obviously, there's been terrific follow-up with our regional hubs, public health hubs looking after those cases. But also there's been less seeding into regional Victoria, which is really important. Happy to take questions.
Can I just ask about how people can think about the numbers? In America, they telegraph, these are our KPIs over 14 days with case numbers and with contact tracing capacity. I think they do the same thing in South Korea and Japan. Why don't we have in Victoria some public benchmark so that we know when the numbers get somewhere what's happening next?
Certainly we'll look to some kind of benchmarking, and we'll have KPIs of a kind in terms of the performance measures that we're looking at. But unlike the US, which is not heading to zero by any stretch of the imagination, we are looking to get to zero community transmission if it is at all feasible. And so that means that there are lots of caveats around what our numbers are. It's one thing to get to 10 cases, but if they're all mystery cases, we don't know where they've come from, and we don't know exactly where to focus our attention and energy in addressing them. That's a trickier problem than an outbreak of 10 cases where they're all known, where the chains of transmission are well established. So there isn't a magic number in that sense. I know people are looking for certainty, and certainly people are looking for some kind of assurance that we'll get to the other side and there'll be a lifting of restrictions. That will be the case.
I guess people just want to have a bit of a better idea of what your thinking is, what your benchmarks are.
It's a smorgasbord of factors. How long are people taking between symptom onset and getting tested? How long are they taking between symptom onset and isolating? How many close contacts do they have for each person? They're all part of the KPIs that we're looking at internally, and that I think we should have available publicly as well. The trickiness is that's 20 plus indicators, and it all interplays in a way that means that we kind of have to make a more organic judgment about where we're headed and what it means in terms of lifting of restrictions, or the kind of lifting of restrictions that we do.
So the bulk of these new cases we're seeing today and yesterday, are they in clusters that you already know about? Are they in aged care, disability? Is that something that gives you a bit of optimism, I guess?
Yeah, a lot of them are. Overnight, we've linked 42 already to outbreaks or complex cases, so that's a reasonable chunk. There are a number that we know are aged care and other healthcare workers. That's both concerning, but also, it is an indication that it's not sporadic community cases where we don't know where the transmission is occurring. But that's one of the factors that we look at over time to see the proportion that are outbreak and cluster linked versus those individual community cases.
So in layman's terms, what your answer to Raf is basically, do you have an idea in your own mind what the figures are that you want to see by September the 13th? And also, do you agree with the Premier that we're a bit more advanced than you expected?
No, I think we're about where I expected us to be. Neither better nor worse. I think, it's great that we're there, but in terms of September 13th, it is a long way away, and it's not just the case numbers, it's not just the new case numbers. I'd love us to be below 50. I would be really gratified if it were in single figures, but I'm not convinced that it will be. I think it's possible, but I think there are really significant challenges to get there. If we were in single figures, I'd be very relaxed.
And does it matter where New South Wales is? Will that affect our decision? If they can't, if they're showing that even where they've come from a good place and they can't get it under 20 a day, does that change your thinking about what we do?
Not entirely. Look, I think New South Wales are doing a terrific job in keeping their numbers below 10 on a daily basis. Their mobility data suggests that people are behaving differently, which is another really good sign that they can stop transmission just because they've got lots of voluntary mask wearing at the moment. People are keeping a distance more in the surveys that they're doing in New South Wales. The proportion of people who are saying they keep 1.5 metres away from everyone all of the time is not insignificant. And so even though they've got some mystery cases, the fact that people are behaving differently means that they do have an opportunity to end transmission in New South Wales with the approach that they're taking. If they've got 200 cases a day, I think it changes our reflections in Victoria, but let's see where they're going. They're doing a terrific job.
Is
New South
15
Wales
new cases
did
in regional
32.
Victoria? Sorry, it's 15 new cases today in regional Victoria. Is that a cause for concern, given it's roughly 8% of our new cases, or is that where you want things to be?
No, I think regional Victoria has been trending down very well as well, maybe faster than Metro Melbourne in terms of the proportion coming down each day. And I think that there's a fair few of those new cases in regional Victoria that are known to be close contacts or part of clusters. Again, that's a reassuring element.
New South Wales did 32,500 tests yesterday. We did roughly 20,000. I realise that part of the fall in testing for us has been because people may not have flu-like symptoms as much because they haven't been mixing as much. But should we be aiming, we're a state with a similar sized population and a much bigger corona caseload. Should we be aiming to be closer to their 30-odd thousand?
I don't think so. I think there's no magic figure in terms of testing numbers. We want to keep it above 20,000. That would be good. I don't know that you get extra value in 30,000 or 40,000 tests necessarily. You push out the turnaround time. New South Wales will be pushing out their turnaround time as they stretch to 30,000 plus cases. And when you've got a long turnaround time for your results, you've got people potentially who are infectious moving about in the community. So there is a balancing act to do there. I think the main thing with our 20,000 plus tests every day is that people who are symptomatic are going and getting tested. That's the primary thing. But in part, it must be that we've had a really long haul in Victoria. We've been doing this for 7 months. It's a bit easier in New South Wales where they've had a quiet period, relatively low testing numbers, and they're doing a real push at the moment, but that's important for them.
Is there an argument to open up testing to people who don't have symptoms, because we are told, a number of people who don't show symptoms but still have the...
Not from my perspective. So asymptomatic testing can have a place where there's a reasonable likelihood that someone will be developing symptoms shortly thereafter, so they're pre-symptomatic, or where there's a real significant chance that they've been exposed. So in an outbreak, in an abattoir where there's a case or an outbreak in an aged care or disability services setting. But in the general population, you've only got like a 1 in 5,000 chance of finding a true case in someone who's got no symptoms. So to do 5,000 tests, again, which pushes out your turnaround time in getting results, is not a good investment in your testing capacity.
Brett, does the data show that health work is about 75% of getting this virus at work?
We've still got the formal analysis and report to come through that Safer Care Victoria and the Chief Medical Officer are leading the way with. But I think it will show that the great majority of infections are occurring in healthcare settings. What we need to dig more deeply into is exactly how those transmissions are occurring. There'll be some that are from patient to staff, but there'll be a number that are also between staff, and we need to actually address all of those transmission chains and all of the potential gaps and learnings that will come out of that report, because it's not simply about addressing PPE, it's not simply about addressing patient or staff flow, it's about all of those systems issues that I talked about.
But that data must be pretty close when there was...
It is pretty close. I would expect it by the end of the week, certainly.
But you said the vast majority are at work or picking it up. It's in some way at work. I thought the other day the Premier was saying the vast majority weren't getting it at work.
I don't
Is
know.
that in conflict? Or?
Yeah, look, I don't know what the reference was, but we had limited finalised data. So there was a huge chunk in those healthcare worker infections where they were still under investigation. So the minority had been determined to be at work out of all of those that were being investigated. But I think when we settle the investigation, it'll show, and we shouldn't be surprised, that they're primarily acquired in the workplace setting, but we need to understand exactly what the transmission pathways are there.
And on the stresses that everyone is under, we know domestic violence is up, we're not sure of the scale, we know self-harm is up. Can you explain how you balance the harm that's being caused versus the harms that you are preventing from happening?
It's a terrible dilemma, and it's not easy, and it's not just for me to address. The whole of government is looking at the potential impacts and all of the things that they're trying to do to reduce those awful harms of isolation and the psychological and health harms and harms from domestic violence that arise. So there is a piece about addressing that, but for me, my understanding is that if you do not address the numbers in terms of coronavirus infections and the spike that we saw either in the first wave or in the second wave, the trajectory of not dealing with that is literally 15,000, 20,000 cases per day. And if the number of deaths we're seeing now is happening with hundreds of cases a day, you can imagine what the burden of illness and death is with thousands of cases a day. And you can imagine what that means for our healthcare staff, the hospital system and intensive care. And that's when, even our 700 ventilated spaces could be overwhelmed.
So are you confident there's still more harm being prevented than caused?
Absolutely. And I think that's the picture around the world in terms of how everyone's responded with the restrictions that are necessary to make sure that it's not unmitigated. When it's literally left to naturally increase exponentially, you see mass graves being dug. That is what happens when you don't address
stage 4 to stage 3 is not the difference between mass graves or not, is it? People get really stressed. They might be a lot happier under stage 3.
Yeah, that's right. I think we need to look at the things that will support all of those important elements in life: people's psychological health, people's access to healthcare, and all of the other dimensions that are important.
Do you have any predictions on what's going to happen to the daily death rate? Do you expect that to stay at a similar level or to drop in coming weeks?
It'll definitely drop in coming weeks, but we'll still see deaths knowing the cases that we're seeing at the moment. But it is somewhat optimistic. I've seen in the numbers that about 15% of our cases are 65 years or above. So that's a minority of our total daily cases. they are the most vulnerable group in terms of dying, and so it's important to see that we're not seeing great numbers. I think our aged care cases, we're getting on top of them in terms of the residents who are getting infected, and that's really useful and important to protect them.
Just in terms of some of the steps you took for aged care about stopping staff moving between different sites, given those lessons, why wasn't that implemented for disability care, given it's a very similar situation with staff moving between sites?
Look, I think people have been looking at that right through. You'd have to ask the disability services area in the department.
Yeah, I guess it might be a question for the
Yeah, it might be a question for the
given
panel.
given it's a policy response, why have you waited, I guess?
Has there been any case studies done to find out exactly how Victorians have got sick and the exact mode of transmission in each case?
Not really. Like our case interviewers go through that process, so they're certainly not just looking at the close contacts while they're infectious to follow up those close contacts and make sure that they're quarantined. They are also going into the 14 days before someone's become symptomatic to try and determine the acquisition, so where they got it from, how they got it. So there is that built into the interviews routinely, but there hasn't been a specific research piece to collate all of that together. It'll be of great interest to understand, but our priorities at the moment are obviously the ongoing transmission and managing the close contacts for every case.
Has sewage...
With those numbers coming down, last week there was some discussion that stage 4 restrictions could be a possibility for some parts. With those numbers coming down, does that mean that you can consider put that off the table, those stage 4 restrictions? And conversely, would there potentially be an argument for regional Victoria to come out of stage 3 a bit sooner?
Yeah, everything's on the table all the time in terms of how the numbers go, but it's absolutely encouraging to see those numbers come down in regional Victoria. And yes, it becomes a smaller and smaller probability that anything greater in terms of restrictions would be required in regional Victoria. That's a true statement for Metro Melbourne. If we're going in the right direction, then the likelihood of needing stronger restrictions becomes less and less. In terms of coming out early, again, we just watch the numbers week by week. I know people want that level of certainty to the extent possible, but we don't know what the tail might look like in regional Victoria. It's certainly coming down at a decent rate now and is looking to be on track for mid-September. But we just need to review it on a day-by-day, week-by-week basis.
Has Victoria done sewage testing? The federal government or the federal advisors are very keen on it. Have you done it? How extensive, and what's it shown?
We have done it. We've been doing it for weeks and weeks. So there have been samples, hundreds of samples collected and frozen. We're now looking at fresh samples because the frozen samples that had to be collected before there was testing that could be done on them they've been degraded somewhat by the freezing process. So we need fresh samples as well, and we're looking at that across Victoria. There's been a significant state investment in that testing capacity, and we're now going through a process of validating those results to see what it tells us. Does it pick up when there's a positive case, for example, in a regional area where we don't have a confirmed case? And if sewage testing is negative, to what degree do we have an assurance that there are no active cases out there? So that's all being worked through at the moment, but we've got an extensive program underway.
And when are you likely to get results?
So there are results coming through now, but they do need to be validated. We need to have the confidence that a positive test in sewage reflects active cases in the community, and we need to have an understanding of how far away would someone need to live from the sampling point in that sewage catchment to give us the confidence that it's telling us the right answer, if you like.
Premier, any more clarity from National Cabinet around those border communities, farmers being able to cross the border?
Professor Thomas Barotti from the Centre of Digestive Diseases says that patients have been treated successfully with the drug ivermectin plus zinc and antibody. He says, we came up with a treatment that is simple, safe and can get rid of coronavirus in almost all patients treated within 6 to 10 days. Has there been any inquiries into that treatment?
I think all treatments are being explored through appropriate research projects in Australia. It's not for me to comment, and it's not really for a single individual, no matter how expert they might appear to be or claim to be to make a claim about their own treatments. It's for a well-constructed research program, randomised control trial with a placebo drug or an alternative arm that demonstrates that it makes a difference. A case series or a case study, that's some evidence, but it's the poorest form of evidence that you can come up with. A well-constructed research program is really how it needs to be investigated. And honestly, it's not for my judgment. It'll be for the Therapeutic Goods Administration and for all the researchers in Australia to look into that. I know ivermectin's been shown in test tube, in vitro, to have great effectiveness against coronavirus. My understanding is that the dose that might be required in humans puts it into toxic levels, and so at the dose that it's given, it may not have effectiveness. And of course, there are, 80% of people are recovering without serious illness. There's that 20% who require hospitalisation or who have severe illness. So it's very difficult to say.